Welcome to AETCM, the emergency medicine channel. Shall I?
Yeah.
Today we'll be presenting a case of 3-year-old boy who presented to our ER with complaints of intermittent episodes of colicky pain since last 2 days, associated with one episode of vomiting on the day of presentation. On PAT triangle assessment, on appearance, child was crying and restless. On breathing, there was no increased work of breathing. On circulation, child was normal in color and extremities were pink in color. Coming to the primary survey, on airway was patent, there was no pooling of secretions. Breathing, respiratory rate, child had 28 per minute with a saturation of 99% and air entry was bilaterally equal. On circulation, child had a pulse rate of 110 per minute with a BP of 100/65 mmHg. Disability, child was irritable and crying, moving all 4 limbs. At this time, since child had pain, we had given injection PCM and the child's weight was around 12.7 kg. So the dose of injection paracetamol comes 15 mg per kg. So we had given 180 mg per kg to the child.
180 mg. Why you want to give IV?
Because the child, on the day of presentation, child was having 2 episodes of vomiting.
Why not suppository?
Suppository also
can be given. See, imagine the child is already irritable. So if really it is indicated, yes, you need to put an IV line. So just for the pain management, we don't need an IV access. So always think that a suppository option is there for the pediatric age group. So you can try paracetamol suppository, 180 mg is available. You can easily give and see how the child is responding to that. So that is one. Orally, as you said, we can't give any pain management. And so what is the first thing that you have to think in terms when your child is coming to the pediatric ER with an acute abdominal pain, or when a child is approaching a pediatric ER? What are the things that you need to consider?
The differential diagnosis?
Differential diagnosis, leave it. For generally a patient coming to the pediatric ER, somebody is bringing a child to the pediatric ER. So what all things you need to keep in your mind? That is my question. So mostly what you need to understand is that pediatric ER presentation, when you overall you look into, majority of the time they need not be in the pediatric ER. That is the first thing. They need not come to the emergency room because of the parents' anxiety, ease of getting access. They are coming to the emergency room. Whatever I say, around 80% of the cases that are coming to the emergency room can be managed on an OPD basis. But when they are coming to the emergency room, but here the child definitely there is an indication there is an acute abdomen. It is not something like a fever episode, single episode, running nose or nothing like that. It's an acute abdomen and the child has come to the emergency room, a 3-year-old child. And the next thing, whenever you have a pediatric age group presenting to the ER, one difference that we know all adults is the vital parameters. So as per the age, we should know what are the normal vital parameters for that age group. That is the first common thing that you should keep in your mind. So for a 3-year-old, you should know what is the accepted heart rate, what is the accepted blood pressure, what is the accepted body weight. So these 3 questions you should be documenting after initially your PAT assessment, or you can do for the wet flags. Wet flags is that what we commonly call the mnemonic. So weight of the child, equipments, epinephrine dose, T is for the tube size and tube length, angle of mouth you wanted to intubate the child. Then wet flags, F is for fluid, how much bolus you want to give. L is for, I think it is the lignocaine. Lorazepam and lignocaine, both you can keep in your mind. F, L, wet flag, A, G. Then is the atropine dose. Then again it comes the joules, how much energy. Again E is for again energy, how much joules of energy that you want to give the child. And final glucose, how much is the glucose you wanted to give for the child. So keep those mnemonics and write it down in the side of your ER sheet. What is the expected weight of the child? What is the size of the tubes? Everything is needed. Or if you have a Brussels tape, that is very easy. So you can just manage and you know what are the vital parameters. So that is the most crucial one what we need to understand. That is the challenge in a pediatric age group. It is not half adult. It is as age advances, till 12 years you have to manage this way only. After maybe 12 years, yes, we can maybe consider as an adult dosing can be given. Majority of the time, 15 years, 16 years, you need adult dosing itself. Okay, so that is the first consideration. Now, let's come to the problem what the child is having is an acute abdomen since last 2 days. So what all things that you will keep in your mind depending upon most common one as the top priority and the least one down. So what will be the most common priority at this age group?
It can be simple acute gastroenteritis can be there.
Okay, so acute gastritis rather than enteritis. The child never had any loose stools. So an acute gastritis can be one of the potential differential then.
Then Intussusception can be.
Okay, why you kept Intussusception little on the higher side at I want to
Because of the age group.
One is because of the age group. What is the age group that when we suspect
Usually
Intussusception?
4 to 36 months, up to 5 years also it can be present.
Yes.
So child is of age 3 years, so we can consider.
Exactly fitting into that then.
Then the type of pain the child was telling, was telling intermittent episodes of pain.
Okay.
So, and which was gradually, like from 2 days, it was gradually progressive.
Okay.
So that is also fitting into the
From history wise, anything else?
child only had 2 episodes of vomiting. There was no loose stools as
But
such.
2 days it is persisting. So that is again, it is not an acute gastritis or something else. It would have gone by this time, but it's still persisting. Then other differentials we can come.
Then simple UTI can be considered in a child.
Okay.
Then if it is a male child, you have to consider for undescended testis and torsion testis. Female child, you have to consider for torsion testis.
Torsion?
Torsion of ovary.
Okay.
Then since they are in the pediatric age group, any anaphylaxis, new food intake should be asked for. Then any trauma history child can have.
Any trauma history is a very important thing because trauma history majority of the time 3-year-old and they will go there and bump and fall down and they will never tell. Only when you evaluate and ask them again and again, they will tell. Maybe they had a small fall at home. Maybe they would have a small minor injury and all. When you have to ask again and again, only they will be telling. So that's an important thing. And one more thing, mesenteric adenitis. So that is one of the maybe little on the upper side we can keep mesenteric adenitis. What about appendicitis?
Appendicitis can also.
Appendicitis may be a little bit lower down. We will not consider appendicitis at the age of 3 years, maybe a little bit on the lower side. So these are the common structures that you need to suspect, and any metabolic or any other causes can come as acute abdomen for this age group.
Rarely.
Okay, fine. Porphyria, that is one, but 3-year-old very difficult to then. Previously, I'm not telling you now, pica history is there. The child is having a pica history. Previously, it is not. Now there are no, even if you are calling it as a lead pencil, there is no lead in pencil. So previously and all, there was lead content. So chronic lead toxicity was one of the reasons for an acute abdomen presentation to the previously, not now. And 3-year-old, because that's a common age group, they will roam around, they can have eating from that. Pica history is the one important thing that you need to ask for. So now not that, but previously you have to think as one of the rarest of the reason why you are having an acute abdomen, and very rarely a cardiac failure. Also cardiac failure, if the child has any other failure to thrive, something else can relate, they can come with some epigastric discomfort due to the dilatation and maybe due to the copulmonal features, they can come with acute abdomen. That is all rare instances. I'm not pancreatitis and all can occur, but again you have some anatomical deformities. So child can come with pancreatitis, divisum and all those things. So 3-year-olds not a very common presentation age group. So these are the common differential diagnosis what you need to keep in our mind.
Abuse also can be suspected.
Okay, child abuse or non-accidental injuries also you have to suspect. So when will you suspect, since you said about child abuse, when will you suspect a child abuse in a patient coming to the ED?
Multiple bruises, contusions over the
From the history you start. Multiple people are giving different history. If you ask child is telling something. If you ask the parent is telling something. The who are being accompanying the child, they are giving different history, which is not correlating with the presentation. So that is the one most important suspicion that you have. Then separated. They are separated. The child is staying with someone else. The child is staying with the stepfather or something. They have a lot of other reason. And the mother and the child is not taking care of the child. Someone else is taking care of the child in the family. So these things, and multiple hospital visits. Then as you rightly pointed out, multiple bruises of different age group. You can have cigarette marks or multiple fractures, all those things. Multiple ED visit for different reasons. You can suspect. But in the situation, it's not that very common. But it can come at any point of time, but child abuse is one important thing that you need to keep back of your mind. So again, trauma related you need to look in for. Okay. So this child, these are our differential diagnosis. Now we need to get a conclusion why this child is what is the final diagnosis. So how will you evaluate this child now?
Sample history.
Yeah, you can continue.
A 3-year-old boy presented to ER with complaints of intermittent episodes of colicky abdominal pain since last 2 days. Initially, the pain was of less severity. Gradually, it got worsened. In between the episodes, child was calm, and during the episodes, child was very irritable and crying. Child also had 2 episodes of vomiting on the day of presentation. No history of loose stools or constipation. No history of blood in stools. No history of fever or dysuria. No history of any trauma. No history of new food intake. No history of recent vaccination. No history of any lesions over the body. Coming to the allergic history, no allergic history. Medications, child is not on any regular medications. Past history, child is immunized up to the age.
Anything significant?
No.
Okay, just one more question I want to ask. Suppose this child is 6 to 8 months of age group and coming to the ED with abdominal pain. What is the most common differential diagnosis that you need to consider?
Gastric outlet obstruction.
6 to 8
6
months.
to 8 food, new food.
So what will evening colic? So that is the most common differential diagnosis that they have to keep in your mind. You have started weaning. So slowly from breast milk, you have moved on to the normal food item. So that time the child might take some time to adjust. So the classical presentation will be the evening time. They will come with colic, evening colic. So that is the most common presentation for that age group, not for a 3-year-old. So now you have come up with a probable list of differential. You don't think it looks like a gastritis. It is intermittent colicky in nature. So something to do with the bowel. So that is what we have come to conclusion. Something to do with the bowel, whether it is a colitis or whether it is an intussusception, or we have to rule out something to do with the bowel. So that is what we have come to a conclusion.
On examination, a child was irritable. On inspection, there was no visible scars or lesions. On per-abdomen, it was soft. A vague mass was felt in the right side of the abdomen, but we couldn't elicit much because the child was not cooperative with the examination.
See, don't want to, because to get to mass in intussusception, it is possible, but sometimes it will not be, you will not be able to see. The child will be holding it very tight. The child is cooperative, only we will be able to elicit that. The classically, you will see empty, you will see a massage, that all is possible. But sometimes in an ER, well, there are a lot of other children, the child will be irritable, crying, you might not be able to get. But that is one of the commonest findings that we need to look in for.
So then we had, since the child was having tenderness, we had kept the child on nil per oral, and then as told, we had given analgesics to the child, and then since the child was kept on nil per oral, we had started the child on fluids. Half DNS was started for the child.
Okay.
And
3-year-old, what is the expected weight for the child?
2x, usually above 1-year-old, we calculate with 2x plus 8. So the child, considering the child's age, around 10 kg, 10 to 15, 14 kg you can go.
Okay.
So the child's weight was 12.7 kg.
So what is the requirement of fluid? How much you need to give it in 24 hours?
Usually we calculate with Holiday Segar formula. First initial 10 kgs we will take 100 ml per kg. Next we will take 50 ml per kg. Next, rest of the weight we calculate 20 ml per kg. So in this child it had come to 1150 ml over 24 hours. So per hourly around 47 to 50 ml.
Then the child has vomiting. So for each vomiting episode you need to replace. Then you need to calculate for your insensible losses also. The child insensible losses will be very minimal for this age group. So around 50 ml per hour is what is required for this age group. So why you preferred half DNS over normal saline or the isolate P?
Because the children in the pediatric age group can develop hypoglycemia.
Anyway, you are keeping him INPO. The child has not taken any feeds. So there is a chance of hypoglycemia, or you want to give energy also to the child. So half DNS you have chosen. Why not fully normal DNS? Because of the tonicity. You have chosen a half DNS.
So kept on NPO, given analgesics, and started.
Which electrolyte you are concerned here?
Child can go into hyponatremia and hypokalemia also.
Only I will be more concerned about hypokalemia, recurrent vomiting, metabolic alkalosis. Again, the vicious cycle of alkalosis, hypokalemia will be there. So usually the practice is they will add 10 milligrams of KCl also to a half DNS. The usual requirement also they will add.
Then we had proceeded with a USG abdomen plus pelvis, and in the USG it showed a long segment ileocolic intussusception with multiple enlarged lymph nodes.
Okay. So there is mesenteric adenitis as well as enlarged lymph nodes.
Lymph nodes. So, since the child didn't have any vitals were hemodynamically stable and there were no features of any peritonitis perforation, we had given consultation for gastro, and then the child was taken up for pneumatic decompression.
Pneumatic decompression. So, intussusception is what the final diagnosis is all about. Can you just briefly tell the common age group, clinical features, 1 to 2, what as an emergency physician? So, treatment option, we can discuss later. Pneumatic reduction is the most commonly done. So, can you just
usually intussusception comes in age group of 4 months to 36 months. The triggering factors may be a recent viral infection can trigger, then vaccination, that is rotashield vaccination can trigger this. Then if the child is a known case of celiac disease, it can cause. Then if there is any lead point, such as like if there is a Meckel's diverticulum, if there is a polyp, if there is a cyst, if there is a tumor, it can also trigger. And post-abdominal surgeries can also be a triggering factor. Then coming to the symptoms will be an intermittent colicky pain, which will be progressive in nature. Then in some cases, you can get a sausage-shaped mass in the right abdomen. Then you can also get red currant jelly stool, that is rarely we get. Then the patient can have vomiting, which is usually initially non-bilious and then becomes bilious vomiting. Patient can have lethargy, and very atypical symptoms are patient can develop altered sensorium, and on examination dance sign, that is the scaphoid abdomen can be seen. Then coming to the investigation part,
peritonitis chances are less here in intussusception. We don't usually see peritonitis. We'll have a local pathology, but very unlikely they present with peritonitis if it is undetected for a long time. But because of the available facilities now, intussusception maybe within 48 hours we are diagnosing and getting it reduced also.
The most common area of intussusception will be ileocolic, and then coming to the investigation, preferred one is the USG.
Why ileocolic?
Because the diameter
ileocolic. Ileum is
small.
Comparatively, ileum or colon, which one is larger?
Colon
is larger, so it will get easily moved out because of the anatomical issue. That is the reason. Telescoping into it.
And then coming to the investigation, most preferred is the USG abdomen. And in the USG abdomen, you can get bullseye sign where you can see both bowels inside. Then X-ray. If we are suspecting any peritonitis perforation, vitals are unstable, then we can go ahead with the X-ray. And if no, even after suspecting no features in USG and X-ray, then only go ahead with the CT, but not preferably not done. And then coming to the management of intussusception, usually we have 3 methods. That is, if the child is vitally stable and no features of peritonitis perforation, we can go ahead with the reduction. Pneumatic or hydrostatic reduction can be done. Usually in pneumatic reduction, we prefer air or carbon dioxide you can use. And in hydrostatic, we prefer normal saline or the contrast. Nowadays, contrast is not usually performed because during the procedure, if a perforation happens, then it can cause more reactions. So we prefer a normal saline. Then if the child has any features of perforation, peritonitis, we take up for the surgery. That can be done.
Okay. So you're planning to discharge the child. Usually 24-hour observation is enough. So the mother is coming and asking, what is the risk of recurrence?
Recurrence is always possible in case of this. Usually up to 24 hours, we look for a immediate recurrence. Even then, after 24 hours, we can discharge. But you have to counsel the mother for if any symptoms reappear, it can be a possibility of recurrence.
So usually after 5 years, usually safe. Till the 5 years of age, they have to be a little bit careful. And if you have found any modifiable risk factors, we have to modify those things. So that is a quick overview of intussusception. Okay, anything else that you want to add?
If at all the child comes in severe hypovolemic shock symptoms,
we have to treat the dehydration.
Dehydration has to be treated. We can classify into mild, moderate, and severe. In mild, 3 to 5% of volume will be lost. In moderate, 5 to 9, and in severe, more than 10%. Usually, the parameters what we look into is the respiratory rate, the BP, and the pulse rate, and then the features like anterior fontanelle, the eyes, the tears in the eyes, buccal mucosa, the skin turgor, the skin temperature, and the urine amount. And also the behavior of the child, whether the child is alert, whether the child is irritable or drowsy. Accordingly, we can classify and then
mild, moderate, severe. And So there is another way is the WHO classification of some dehydration and with moderate and severe dehydration. That's the other one. So the take-home message is that whenever the patient is having mild dehydration or whatever be the dehydration, the fluid replacement is the key. Orally, if the child is able to take, well and good. If or not orally, you have to start on an IV fluids, Holiday-Sagar formula, and most importantly, when you have hypotension, because hypotension, the Holiday-Sagar formula will not apply at that point. We have to treat the hypotension at 20 to 30 ml per kg, and you can give multiple boluses, maybe up till 60 ml per kg boluses can be given, followed by your maintenance, insensible loss, each episode diarrhea, loose to loses, all those things you need to correct. And remember always regarding electrolyte correction also, and energy with electrolyte, not just the fluid, electrolyte and energy replacement also need to be considered. Fine. Thank you.